Hello everyone, this is Dr. Sekioba with the second part of chapter 58. This time we are going to talk about multiple sclerosis. Multiple sclerosis, by definition, it is a chronic progressive degenerative disease of the CNS, and it is characterized by segmental demyelination of the nerve fiber of the brain and the spinal cord. I hope you do understand that. Basically, demyelination, it means losing the myelin of the nerve fiber of the brain and the spinal cord. So, in terms of the onset, usually multiple sclerosis can affect people of any age. The onset of multiple sclerosis is usually between 20 and 50 years of age, with symptoms first appearing at an average of 30 to 35 years of age. People are diagnosed at 50 years of age, usually, or older, and these people are generally possesses or have more progressive disease. So that means they have more than one disease that is present at the moment. Women's are more affected, 2 to 3 times more than men. So it is commonly found in women more than men. So, in terms of the statistic, there are more than 400,000 people in the United States that have multiple sclerosis, with approximately 10,000 new cases diagnosed annually. Multiple sclerosis is more prevalent in temperate climate between 45 to 65 degrees of latitude, such as those found in the northern of the United States, Canada, and European, as compared with a tropical region. People who are born in the area of higher risk but migrate to an area of low risk before the age of 15 assume the risk of their new homes. So basically, what is this saying? It's saying that people who are born into the higher risk area of developing this disease, when they move out, they might not necessarily be at a reduced risk for multiple sclerosis, but however, they will be at a new risk of developing, at a new lower risk of developing multiple sclerosis. Research does suspect that exposure to some environmental agent before the puberty may predispose a person to develop multiple sclerosis later on in life. Multiple sclerosis is less common in Hispanic, Asian, and the people of African descent. It rarely occurs in some of the ethnic groups, such including Alaskan, Native, and Aborigine, and of those who are origin of the Alaska, basically Alaskan Native. That's all you got to know over here. So, the cause of multiple sclerosis, just like any other neurologic disorder, although the cause of multiple sclerosis is not known, it is unlikely to be related to a single cause. The disease develops in genetically susceptible person as a result of environmental exposure, as stated a few seconds ago, and such as those people who are exposed to infection. Of course, infection of the CNS. People, a possible precipitating factor including infection, smoking, physical injury, emotional stress, excessive fatigue, pregnancy, and the poor state of health. The role of precipitating factors such as exposure to pathogenic agent is controversial, however. More than a dozen of viruses and agents more than a dozen of viruses and bacteria have been investigated, but none has definitely been proved to be the cause of multiple sclerosis. Multiple genes are believed to be involved in the inherited susceptibility of multiple sclerosis. Having the first degree relatives, that means a brother or a sister with multiple sclerosis, increases a person's chance of developing the disease. A common genetic factor have also been found in families with more than one affected member by the disease of multiple sclerosis. So, in terms of the etiology and the pathology and the pathophysiology, basically, as I said earlier, an unknown trigger in genetically susceptible individual may initiate this process. Okay, and this it is characterized again by chronic inflammation, demyelination of the nerves in the CNS, and the gliosis. Gliosis, by definition, it is basically the scarring in the CNS. And what we know about that, once the nerve develops certain scars in certain area, then the conduction of the nerve electricity will be affected as well. So the also primary neuropathologic condition is also an autoimmune process which is orchestrated by the activation of the T cell. Okay, so people with T cell issues also are at the risk of developing of this kind of disease. All right. Okay, so in terms of the T cell, once more, basically activated T cells migrate to the CNS, which will cause a disruption between blood-brain barriers, and that will result likely in the initial event in the development of the multiple sclerosis. These people subsequently they will develop antigen-antibody reaction that will lead to demyelination of the axon. And remember, you have to know exactly what is the difference between the axon and the other type of the other part of the nerve conduction system, because as we know that the difference between the axon and the dendrite part of the conduction system of the nervous system, you know that the axon basically it took impulses from the certain part of the body or from the peripheral part of the body to where the neurons. So anytime that there is a disruption in the axon of the nerve, then the conduction is not going to be the same. Okay. So over here, what you can see on this picture, it is the illustration of different parts of the nerve that are affected in those people who have multiple sclerosis. For example, in picture A, you have a normal cell with a myelin sheet on it. Basically, it's very well covered. There's no problem going on there. In picture B, basically, you have again a normal axon. Okay. Again, you need to know exactly what the function of axon. In a picture C, you have basically a myelin that is starting to break down. In a picture D, basically there is a breakdown of a totally disrupted axon, and basically this axon is not going to function like it's supposed to. So initially the transmission of nerve impulses still occur, but it is slowed. It progressively gets worse. At this point, when this happens, myelin can regenerate and symptoms will disappear. At that point, the patient experiences what we call remission. In terms of the as this continues, as the ongoing inflammation continue to happen, nearby oligodendrocytes are affected, and the myelin loses the ability to regenerate. Eventually, damage happens to the underlying axon. Nerve impulse transmission, basically, it is at this point where it's disrupted, so there is no connection between the nerve conduction, which will result in permanent loss of nerve function. Again, you may see a picture in your textbook 58-3, letter D. As the inflammation subsides, the glia scar's tissue replaces damaged tissue, leading to formation of hard, sclerotic plaques. These plaques are found throughout the white matter of the CNS. The picture here, it is exactly illustrating of what happened when there is a demyelination plaques at the gray-white junction and adjacent partially remyelinated. Basically, there is a regeneration, shadow plaques, which it is shown by the letter V in the picture. These plaques are found throughout the white matter of the CNS. Okay, so the clinical manifestation of the multiple sclerosis, the onset of the disease is often insidious and gradual. Basically, it progresses slowly. The symptoms are very vague, sometimes hard to distinguish. It happens intermittently over months or years. Then there will be not enough to seek medical attention because people think it's a common disorder that's happening. The disease also it is diagnosed long after onset of the first symptoms. However, there is always, because of the slowly progression of the disease, sometimes people tend to confuse multiple sclerosis with other type of disorder of the CNS. So in terms of chronicity of the problem, again, it is a chronic progressive deterioration in some of the patient. It depends again on the genetic and also on the comorbidity of the patient. Okay, remission and exacerbation in other, it happens quicker than the other. The overall trend is progressive in deterioration and basically in the neural functions as well. So, in terms of the symptoms manifestation, basically symptoms vary according to the area of the CNS that is involved. Some have severe, long-lasting symptoms early in the disease. Others have occasional and mild symptoms for several years. That could be maybe 2 to 3 years around the road. So this table here is found in your textbook. It exactly gives you the different category of the progression of the multiple sclerosis. So you have, for example, the relapsing, remitting. Basically, it's relapsing remission here. Basically, it is telling you exactly at the stage how it gets worse slowly but slowly. It goes from relapsing remission, primary progressive, secondary progressive, and when it gets to progressive relapsing, basically that is where the disease has it is progressive from the onset with a clear acute relapse with or without a recovery period between the relapse, or which is also characterized by a continuation of the progression. Basically, over here, the patient just continue to get worse. So, in terms of the first symptom that you may see, patient may complain of blurred vision, double vision, red-green color, the distortion. Do never confuse this one with some certain side effect of certain medication. For example, if the patient is on digoxin, they may tell you that they have a problem distinguishing the color, especially a green halo color. So you have to rule that out. Or even patient, if they say they are getting blind, you want to make sure that they are not getting blind from any other type of chronic disorder such as diabetes and so forth and so on. Okay. So in terms of the other different type of the common manifestation, the average life expectancy after the onset of the symptom is more than 25 years. Death usually occurs as the result of the infection or complication, example pneumonia, and immobility because of the unrelated disease. Basically, these people will tend to die from the secondary infection that is caused by the body inability to fight to fight or to get rid of the infection. Many patients describe muscle weakness in the extremities as well as problems with coordination, balance, and those symptoms may even affect walking or standing. Multiple sclerosis can cause a partial or complete paralysis in the worst case scenario. And the other frequent problems include speech impediment, tremors, and dizziness. Hearing loss is also an occasional finding at, at times. In terms of sensory manifestation, of course, most people also experience a paresthesias or numbness and tingling in the extremity. Some patients complain of pain, especially in low thoracic and abdominal area. Hearing loss is also an occasional finding. A patient with multiple sclerosis experience a variety of sensory abnormality. We have what we call a Lemierre's sign is a transient sensory symptom described as an electrical shock radiating down the spine or into the limbs with flexion of the neck. So in terms of the cerebellar manifestation, cerebellar signs include nystagmus, ataxia, dysarthria, and dysphagia. Severe fatigue is present in many multiple sclerosis patients and causes significant disability for some patients. The fatigue is aggravated by heat, humidity, and the conditioning and medication side effect, of course. In terms of the bowel and bladder function, that also may be affected. Bowel and bladder function can be affected if the sclerotic plaque is located in the area of the CNS that control elimination. Problem with the defecation, which is basically bowel movement, usually involve constipation rather than a fecal incontinence. Urinary problems are viable. A common problem in patients with multiple sclerosis is a spastic, which basically it's inhibited bladder. As a result, the bladder has a small capacity for urine, and its contraction are basically unchecked. Basically, this is where you have urinary incontinence, which could be either the urinary agents or frequency, often accompanied by a dribbling or incontinence. Okay, now you have a flaccid, which is basically the other term of saying hypotonic bladders, which indicate a lesion in the reflex arc controlling the bladder function. Also, you may have a flaccid bladder, which has a large capacity for urine because there is no sensation or desire to void for pressure. Basically, if there is no nerve that is telling the bladder is full, so it will continue to extend. It will be basically hypertrophic, getting bigger. Therefore, the capacity may increase in terms of the effect of the bladder due to a problem with nerve conduction to that region of the body. Generally, the patient has urinary retention, but urgency at the frequency may also occur with this type of lesion, as I just said a few minutes ago. Another urinary problem is the combination of the previous two. So basically, urinary problem cannot be adequately diagnosed and treated without urodynamic studies. So this patient, they will be referred to a urology to determine exactly what will be the course of action in addressing their problem. So in terms of sexual dysfunction, this can happen also in people with multiple sclerosis. That we have a diminished sensation. Remember, in this type of disorder, basically the nerve conduction system has been affected. So of course there will be a diminished sensation that can prevent a normal sexual response in both men and women. The emotion effect of chronic illness and loss of self-esteem also can contribute to the loss of sexual desire and sexual response. Some women with multiple sclerosis who become pregnant experience remission or improvement in their symptoms during the gestational period. Hormonal change associated with pregnancy, of course, appear to affect the immune system. However, during the postpartum period, women are at a greater risk for exacerbation of the disease. So, in terms of cognitive manifestation, basically about half of people with multiple sclerosis will experience some problem with cognitive function, general intellect, including long-term memory, conventional skills, and the reading comprehension remain unchanged and intact. Symptoms can be mild and because of such easily overlooked. However, cognitive changes are so severe in about 5 to 10% of multiple sclerosis patients that they significantly impair the person's ability to perform activity of daily living. Most of the time, cognitive difficulties happens later in the course of the disease. However, they can happen much earlier in the disease process, and occasionally they are present with the onset of the multiple sclerosis. In terms of the emotional management, uh, patients basically they will be frustrated because they cannot care for themselves, and they may become very angry. They may appear diffused. They may appear depressed and euphoria at times. And basically, what I'm saying here is a physical, emotional trauma, fatigue, and infection may be aggravated or triggered or serve as a trigger of sign and symptom of this disease. So, in terms of the diagnostic study, there is currently there is no definitive diagnostic test for multiple sclerosis, and basically, the judgment or diagnosis is based primarily on history, clinical manifestation, and the result of certain diagnostic tests, such as a MRI of the brain and spinal cord, may show the presence of plaques, inflammation, atrophy, and the tissue breakdown and destruction. So in terms of basically cerebrospinal fluid, this is where they can do a spinal tap or fine needle aspiration of the spine. There will be an increased immunoglobulin G. There will be a presence of oligoclonal binding, and then there will be an evoked potential response are often delayed in a person with multiple sclerosis. Remember, the reason for the delay in the potential response, it is because again the conduction system has been blocked because the nerve has been degenerated or basically has been cut down. So there's no direct communication between the efferent and the afferent nerve conduction system. I hope you know exactly what I mean by efferent and afferent conduction system. So evidence of at least two inflammatory demyelinating lesions in the last two different locations within the CNS must be present in order for somebody to be diagnosed with multiple sclerosis. If evidence exists only for one lesion or one clinical attack, then one clinical attack has happened. The healthcare provider will have to monitor the patient for another attack for an attack at different sites of the CNS. What does this saying is that basically if it happened once, it's going to happen again. The beauty of the treatment, and I will talk about this later on as we move forward, is that we are able to slow down the progression of the disease, but as we know, there's no cure for multiple sclerosis. Okay? So basically the damage or attack sometimes it happens at different times, usually 1 month in between, All other possible diagnosis must have been ruled out before you can really confirm that this patient is having multiple sclerosis. Okay, in terms of treatment, basically table 58-12 in your textbook and 58-13, it gives you more information on how to treat this type of disorder, or what is used for the treatment of multiple sclerosis. And disease modifying therapy has been found to be more effective when initiated early in the course of multiple sclerosis. Delays in the treatment have been associated with a poor outcome. So again, remember, primary prevention is the key. That means getting early intervention after early screening. It is the key to prevent the worsening or the catastrophe outcome from this disorder. In terms of immunotherapy, research are basically saying that treatment of multiple sclerosis begin with use of immunomodulator drugs to modify the disease progression and prevent the relapse. Again, there is no cure for multiple sclerosis. All we can do basically is to slow down the progression and the worsening of the disease. And such may be the use of immunosuppressant, immunomodulator, and adrenocorticosteroid hormones in order to prevent the disease to become worse. So the immunomodulator basically in terms of using them to treat multiple sclerosis, this begins with the use of the drugs to modify the disease progression and to prevent the relapse. These drugs include interferon beta 1A, which also over here in your textbook it gives you some of the generic and the brand name of this type of drug, and basically such as Rebef, Pregridly, and other interferon B type 1A, which is Avenox, which is given intramuscularly. Interferon basically interferon B-1B, it is another one that is used, which is beta-seron, Extavia, given subcutaneously at times. Okay. Also, you may give a medication called glutaramyl acetate, which is a Copaxone, spelled as Copaxone. It is also given in subcutaneously to the patient who might be having multiple sclerosis. So these are basically other type of medication that can be used. Over here we have teriflunomide, which is Abugatio, and then you have the immunomodulator agent with anti-inflammatory properties. Such include basically the other drug we just mentioned a few minutes ago. Now you have what we call a fingolimod, which is also the other name of Gilenya. Basically it is used to reduce the multiple sclerosis disease activity by preventing a lymphocyte from reaching the CNS and causing damage. Most of these drugs are specifically indicated for treatment of relapsing of the multiple sclerosis. So what is this saying? Once we discover that somebody has really multiple sclerosis, all we are trying to do is we are trying to make sure they don't relapse again, or even if the damage has been done already, we're trying to make sure that the damage does not progressively get worse. So other therapy that are used, we have a more active, aggressive form of multiple sclerosis, such as natalizumab, which is Tabri, and then you have Lematrada, and then you have Novatroni, and the other type that are listed in your textbook, basically, and or you can read them over here on this slide. I am not gonna go, or I am not gonna read all of them one by one, but on the only thing is, the one thing you got to know on this medication, you have to know that an adverse effect of this medication basically could put somebody at increased risk of progressive multifocal leukoencephalopathy, which is a potentially fatal viral infection of the brain. And because of such medication such as alemtuzumab is generally reserved for patients who have inadequate response to two drug or more as indicated for treatment of multiple sclerosis. So what it is saying is that some of these drugs, they cause a severe adverse drug reaction, but there is a certain drug such as alemtuzumab. It's spelled as ALEMTUZUMAB. It is one of the medications that has been reserved for patients who have inadequate response to the other type of medication used to treat multiple sclerosis. And you have this drug called mitoxantrone, spelled as mitoxantrone. It is an antineoplastic medication that has a serious effect, including cardiotoxicity, leukemia, and infertility. So before you give this type of medication, you have to ask the patient intent to bear children, if this is a woman in the childbearing age. And then you have some other type of medication such as dimethyl fumarate, which is spelled as DIMETHYL, fumarate, which is spelled as FUMARATE. This provides a new approach into treating multiple sclerosis by activating the NRF2 pathway. I will really strongly encourage you to exactly look up what NRF2 pathway. This pathway basically it provides a way for cells in the body to defend themselves against the inflammation and oxidative stress caused by multiple sclerosis. All right. So in terms of corticosteroid, there comes our very good old methylprednisolone. I hope by now you know what methylprednisolone is, right? And if not, at least I know you know what is prednisone. If you still don't know what methylprednisolone is, let me tell you, it's basically the other name of that, it's Saliomedro. Okay, we use again this type of drugs basically to help in slowing down the inflammation process that is associated with this type of the disorder. And we also use this type of medication, remember, in people with acute asthma attack. And basically, what does these drugs do? They reduce the edema and acute inflammation at the site of the myelination. Therapeutic plasma exchange and IV immunoglobulin G is something to monitor very closely. Okay, so and in terms of the other drugs, you may also use a muscle relaxant, which are used basically for the spasticity, and you also may use the drug called amantadine, which is a Simatrol, and the CNS stimulant, which is a Pamolin, PEMOLINE, and much more. Also, you may use the stimulant called Ritalin, and I am sure you go like, oh, Ritalin, what do we use Ritalin for? We use Ritalin in people with ADD. Remember, what we are trying to do here is basically we are trying to give a boost to stimulate the brain, hoping that there will be a more successful conduction system where the nerve can effectively and efficiently communicate with each other. And then we have some anticholinergic, which are used to treat basically the bladder symptoms. Tricyclic antidepressant and anti-seizure drugs are also used for chronic pain syndrome. And then you have your Ampira, which is spelled as AMPYRA, which is used to improve walking speed in multiple sclerosis patients. Again, it is a selective potassium channel blocker, and it improves nerve conduction in the damaged nerve segment. It should not be used in patients with a history of seizure disorder or moderate to severe kidney disease. So if people have kidney disease, they should not use this kind of drugs. Okay. So in terms of other intervention that may be required in treatment of spasticity, spasticity is primarily treated with a muscle relaxant. However, a surgery examples such as neurectomy, rhizotomy, and the chordotomy, which is the dorsal column of electrical stimulation, or intrathecal baclofen, which is another medication called radioriso. These are delivered by the pump, may be also required or used. Tremors, muscle tremors that become unmanageable with the drug are sometimes treated by thalamotomy and or deep brain stimulation. Okay, now we have what we call exercise with multiple sclerosis. Basically, what you are trying here is trying to neurologically stimulate those neurologic dysfunction, which sometimes it can show some improvement with the physical and speech therapy. Exercise improves daily function for the patient with multiple sclerosis who are not experiencing or exacerbate who are not experiencing basically the exacerbation, or who are not experiencing an acute attack. Exercise decreases the spasticity, and it increases the coordination and retrain the unaffected muscles to substitute for those that are affected. Basically, what we are trying to train the muscle is basically is to compensate for those muscles that had been affected. Now you have what we call a water therapy. Especially this is beneficial type because of the physical therapy that is associated with it, that comes with basically exercise. Water, which gives basically a buoyancy to the body, allows the patient to have more control over the body and perform activity that would normally be impossible for them to perform on their own. So in terms of collecting subjective data and objective data, that should be obtained from the patient with multiple sclerosis. Basically, you wanna subjective data. Again, you wanna history. You wanna ask the patient about any viral infection or vaccination, resident in a cold or temperature climate, physical and emotional stress, medication elimination problems, weight loss, dysphagia, which is basically difficult swallowing. In terms of health assessment history, you want to ask for any muscle weakness, fatigue, tingling, numbness, muscle spasm, blurry vision, a loss of vision, diplopia, which is basically double vision, vertigo, tinnitus, which is the ringing from your ear, decreased libido, impotency in men, and anger, depression, euphoria, and isolation. In terms of objective data, you are going to observe the patient closely for apathy, inattentiveness, pressure ulcers, scanning speech. Basically, they cannot give you a clear speech. Tremors, nystagmus, ataxia, and spasticity of the muscles. Um, Basically, patient will have a hyperreflexia, decreased hearing at times, muscular weakness, paralysis, paresis. You have a difference between paresis and paralysis, foot dragging, dysarthria, and so on. Nursing diagnosis, you would have impaired physical mobility, impaired urinary elimination, ineffective health management. Basically, because patient we have to be able to conduct this because they have no clear initiation because the conduction system is really impaired. Okay, so additional information on nursing diagnosis for the patient with multiple sclerosis is present in your nursing care plan in your textbook in the table 58-3. So in terms of the planning for the patient, the goal are basically that the patient with multiple sclerosis will, one, maximize neuromuscular function, two, maintain independency in activities of the daily living for as long as possible, three, manage disabling fatigue, 4. Optimize psychosocial well-being. Basically, 5. You want to help the patient to adjust to the illness and basically reduce the factors that precipitate or exacerbate the disease. So you are going to assist the patient basically to be independent, identify patient needs that can be met when you are together. Basically, each person responds differently to this disorder, so you're gonna understand that certain patients, they progress very well, they respond to the therapy that you may provide very well, and some of them they might not. So during the diagnostic phase, the patient needs to be reassured that certain diagnostic study must be done to rule out that other neurologic disorder, even though a tentative diagnosis of multiple sclerosis has been made. Because don't already come up and say finally, for final you do have multiple sclerosis. You don't say that. You are going to assist the patient in the dealing with the anxiety caused by the diagnosis itself, and then the patient with recent diagnosis of multiple sclerosis may need different assistance, such as the grieving process, and maybe you may want to refer the patient to a support group. If they need a social worker, then you might get a social worker involved, just to help the patient to easily adapt to the development of multiple sclerosis. So in terms of basically the nursing implementation, during the acute exacerbation, the patient may be not able to move and may be confined to bed. So the focus of nursing intervention at this phase is to prevent a major complication of immobility, such as respiratory or urinary tract infection and pressure ulcers. Pressure ulcers, it's very important to assist the patient, to turn the patient every 2 hours or as often as possible. Make sure you get the family member involved so that they can help you in caring for this patient. You also want to make sure that your care involves avoiding exposure to cold climate, because and to people who are sick, as well as vigorous and early treatment of the infection when it happened. So what I'm saying here is basically you are going to make sure that people who are early diagnosed with this type of disorder, you want to make sure that they don't get exposed to severe cold, because otherwise this may speed up the aggravation of their disease. Okay, so in terms of teaching, you are going to teach the patient about the treatment regimen, drug side effect, how to identify and manage side effect of this drug interaction, especially with the over-counter medication. The patient should really call their primary care provider before taking any non-prescription drug, once they have been diagnosed with multiple sclerosis, or once they have prescribed some medication to help them with multiple sclerosis. So you are going to most of these patients, they will have a problem with bladder control. It is a major problem for many of these patients. Even though when we put them on anticholinergic, that may be beneficial for some of the patients to decrease the spasticity You may need to teach them how to do a self-catheterization, because if these people, they are already affected, they have already been in trouble with their bladder emptying, so they will go home with a catheter, a kit to self-catheterize at home. So bowel problem, particularly constipation, it happens frequently in patients with multiple sclerosis. Increasing the dietary fiber intake may help some patients to achieve regularity in bowel elimination. The patient with multiple sclerosis and the caregiver need to make many emotional adjustments because of the unpredictability of the disease, and the need also to adjust in lifestyle, and the challenge of avoiding and decreasing precipitating factors. The National Multiple Sclerosis Society and its local chapters can offer a variety of services to meet the need of the patient with multiple sclerosis. So therefore, you can go online, identify if there's any supportive group on multiple sclerosis in the area where the patient lives. So in terms of what did we expect from our intervention, basically the expected outcome are that the patient with multiple sclerosis will maintain or improve muscle strength and mobility, a use of assistive device appropriately for ambulation and the mobility, maintain urinary continency. So you want to make sure that these patients, they are safe, because they are at risk for any time. You are going to make a decision that basically the other goal, it includes that the patient will be able to make a decision about health and lifestyle modification necessary for the management of multiple sclerosis. Additionally, information expected outcome for the patient with multiple sclerosis are presented in the e-nursing care plan found in your textbook under the table 58-3. And